So let's move forward a little bit and let's talk about that, because we've talked a little bit about mepolizumab, we've talked about Xolair, omalizumab, and we have now 5 products on the market, right? So what are the differences in mechanism of action between these different therapeutics? Are there biomarkers that help us to identify one therapeutic as perhaps being more favorable in response based on those biomarkers? Nick, do you have a thought?
Well, we talked about the asthma phenotypes and looking at eosinophilic versus allergic. There's quite a bit of overlap. Obviously, when you're using omalizumab, you're really targeting allergic asthma. It's only been tested in those patients who have perennial allergies, documented either by skin test or RAS testing. And certainly the studies have shown, at least the real-life studies, shown that blood eosinophils don't really play a role in determining response to omalizumab. But
I think that's important because even in the French study just published in European Journal showed us that even at low eosinophil counts there was a salutary response to omalizumab. So in the Humbert study that was helpful, I think, information.
Yeah. On the other hand, the anti-IL-5s, there are 3 of them. Blood eosinophils are important determinant of response. Also severity of the disease. The higher the exacerbation rate, the higher blood eosinophil, the better response to anti-IL-5. Doesn't matter which one you're talking about.
And possibly to IL-4/13 drug too.
So with IL-13, it's interesting, and we'll talk in more details about it. Blood eosinophils seem to be also a good determinant, but also exhaled nitric oxide level is a good sort of predictor of response because it's a T2, targeting T2 high asthma. So there are certain biomarkers that help us. Having said that, there's quite a bit of, you can see that there's quite a bit of overlap. For example, an anti-IL-4 can lower IgE, and it does work in allergic asthma as well as eosinophilic asthma. Anti-IL-5, there's a subpopulation of allergic asthma that responded to anti-IL-5 therapy if they have high blood eosinophils. I know Brad presented at this QuadAI meeting some data from omalizumab showing that it can lower blood eosinophils. But the data are not, the high blood eosinophil patients respond as good as low blood eosinophil in at least real-world studies. So there's quite a bit of overlap. So I think the choice of which one to use will rest on several other things, including the comfort of the clinician, but the patient also. That's where, patient decision-making, shared decision-making is important.
And looking at comorbidities too, I think,
and comorbidities
is very important as we have a discussion about whether to use to attack the IL-5 pathway, the 4/13 pathway. If they have nasal polyps, and atopic dermatitis, you're going to tend to mitigate to the 4/13 pathway, as opposed to just pure eosinophilic disease with or without nasal polyps. You may decide more that the IL-5 pathway you need to attack first.
Right.
Something that struck me is that there's a difference in the population of patients who, all type 2 high, who may appear to respond to omalizumab than those who respond to the anti-IL-5 drugs. Omalizumab was initially tested in mild to moderate asthma, allergic asthma, was shown also to work in severe asthma, in sharp contrast to the anti-IL-5 agents, which in all-comer asthma really didn't do very much.
Almost killed it to start out with.
Only when a very specific class of patient was identified that Nick has discussed before, who truly has persistent eosinophilia despite high-dose anti-inflammatory medications. When you look at the patients that were in the studies, they were really quite remarkable.
Late onset disease.
Despite those medications, they were having 2 to 3 exacerbations a year and had around 30 to 40% reversibility. So it's a very distinct class of patient, very different from the omalizumab responsive patient that appeared to be across a broad spectrum. And I think perhaps the anti-IL-14 at 4/13 may have a different population. Again, it may be broader than the anti-IL-5s. So it's not just based on the markers we should be deciding, it's based on the phenotype of that patient. The anti-IL-5 patient in the study was a very interesting subset of asthma.
I think that's an important point, is that, I think when you think about, the way I think about sort of this IL-5 therapies and this really high eosinophil levels, not necessarily very, very high, but certainly you see that bigger response in those patients that have more eosinophilia,
Right.
more exacerbations. It is important to note that, when I think about eosinophils, I think about them as an amplifier of this immune response that's sort of already sort of going on, right? And then coming back to Xolair, I'm curious to know your thoughts, and I'd love to hear your sort of thoughts on this Prospero trial. You go back to the initial studies in Xolair, the placebo-controlled trials, and there were 2 trials that came out positive, one that wasn't quite so positive in that severe population that were on LABAs plus high-dose ICS. But then we see Prospero showing that maybe there is an effect, and we bring into ideas about adherence, et cetera. So how do we put all of this together?
I think you have to look at the age of the patient. So the 6 or 12 group, you've got to give over to omalizumab. And I think you have to look at the intensity of the eosinophilic signal in the peripheral blood compartment and the airway compartment. And you have to look at comorbidities and decide what you have the best chance of fixing
One other
and go
thing,
for that.
Yeah, I agree with that. And one other thing we didn't talk about is oral steroid-dependent asthmatic, which seem to be favoring the anti-IL-5 if they have high eosinophils, but certainly with anti-IL-4, dupilumab has an indication now for oral steroid-dependent
It's the only
asthma,
one that has an indication for oral steroids in
regardless
their
of
package insert.
eosinophil
Right.
count. So I think with omalizumab, we had some data from at least the extra study that I led to show some effect, but it's not a strong effect as those patients on just ICS and LABA.